Evening. My name is Dr. Maria Rodriguez, and I am pleased to be the moderator of this informative, interactive, and timely webinar highlighting AI and its impact on us as physicians. I'm the Vice Chair of the Tulane University School of Medicine Board of Governors, along with the Co-Chair of the Engagement and Development Committees. I received my medical degree from Tulane University School of Medicine in 1988. I am currently the Chief Clinical Advisor at Envision Physician Services Radiology Division, and I am a practicing mammographer and radiologist. During the webinar tonight, you will have an opportunity to share your questions via chat. We may not be able to cover all the questions yet, we will certainly do so following the event. With us tonight, in sharing their expertise, we have three physicians, Dr. Adam Rodman, Dr. Shayan Chakraborty, and our fourth-year medical student, Alexander Stoller. Dr. Adam Rodman, our main speaker, received his MD degree at Tulane in 2013. He is a general at Beth. If you can please mute. At Beth Israel Deaconess Medical Center in Boston, Massachusetts. He's an instructor of medicine at Harvard Medical School and the co-director of the iMed initiative at BIDMC, which is dedicated to the study, promotion, and best practices of digital education and artificial intelligence. He's also a medical historian focused on the evolution of medical epistemology, especially the history of diagnosis. He is the host of the medical history podcast, Bedside Rounds, and commonly appears in the media. His first book, Shortcuts Medicine, was released this year. Our next presenter is Dr. Shayan Chakraborty, who is currently Associate Dean for Education and Academic Affairs and a Professor of Medicine at Tulane University School of Medicine. After receiving a Bachelor's of Science degree in Biology and a Bachelor of Arts degree in Philosophy from Duke University, Dr. Chakraborty received his medical doctorate from Tulane University School of Medicine. He completed a residency in internal medicine at Tulane and a general internal medicine fellowship focused on medical education at Johns Hopkins. Previously, he served as internal medicine clerkship director, director of student programs, director of career advising, and a course director for the Foundations in Medicine, which is an introduction to clinical medicine course. Dr. C, as he is known, has been recognized with numerous awards in teaching, humanism, and student advocacy. He has been a multi-time recipient of the Award for Outstanding Teaching Attending and Best Clerkship. In 2014, he was inducted into the Tulane Society of Teaching Scholars, and in 2019, Dr. Chakraborty was awarded the Presidential Teaching Award for Graduate and Professional Teaching, which is the highest such institutional award at Tulane University. Alexander Stoller is a fourth-year medical student at the Tulane University School of Medicine and is currently applying to residency in emergency medicine. He previously received a Master's of Science in Microbiology and Immunology from Tulane University and spent 11 years working in various national security positions in Washington, D.C. as an analyst and technical director in the field of counter-proliferation. He received his BA in International Relations and Political Science from Carleton College. At this time, it is my pleasure to turn the program over to Dr. Rodman. Dr. Rodman.
Thank you very much for the generous introduction, Dr. Rodriguez. And hi, everybody. My name is Adam. You can call me Adam. I'm incredibly excited to be here. I'm going to go ahead and start because we have hopefully a very exciting presentation for everybody. You'll excuse my cough. I have children ages 5 and 3, and I have had a cough for, almost a month. Children are both the best and the worst. So today, this presentation is called The AI Doctor Will See You Now. Just to give an overview of what we're going to be doing today, I'm going to start by talking about my own research, of course, but talking about what is clinical reasoning and why we as physicians care about it. I'm going to give a very 20,000 layperson view of how large language models work. I'm going to try to do all of this in less than 10 minutes. Big subject, I know. Then we're actually going to demonstrate the technology live with Dr. Stoller and Dr. Chakraborty. And then I'm going to go over the evidence, including a lot of my own research, before turning it over for questions and reflections. So with all that, let's get going. What is clinical reasoning? If you were to ask 10 different clinical reasoning researchers or experts, you'll get different answers. It's actually a pretty complicated domain, generally called or formally called medical decision-making. The idea that it is the study of how doctors make really any sort of decision, but really focus towards diagnostic and management decisions. There are two broad strains of thoughts that go back a long time, right? We've been talking about this for over 150 years. You can divide them into roughly two categories. The first, I would say, is the positivist view. This used to be called as intuitive, right? You'd say, oh, people just know what the answer is, versus a normative view or the so-called analytical view. This is more of if you think like, if anyone has told you, oh, it's all a sense of probability. You know what the pretest probability is, how our test characteristics change, what the diagnosis is, so-called Bayesian reasoning. So there have been debates back and forth for over 150 years on those two rough strains of clinical reasoning. We currently have, let's say for the last 20 to 30 years, is a grand unified theory on how doctors think, largely informed by cognitive psychologists, and we've kind of stopped arguing about it. So in case it's been a long time since you took a psychology class, this is based in the work of Kahneman and Tversky, the idea that there are two systems to how humans make decisions, a system that is very fast, highly context dependent, uses heuristics or rules of thumb, and with a tendency to make errors. That's our system one. System two is context independent. It is slow. It is very deliberate. It is very taxing. That is the system two. Don't worry, this is not a lecture, so I'm not going to go over, but this is kind of the overview on how we understand that these two systems help doctors make decisions. I'm going to give you an example that's more practical for anyone who takes care of patients. And that's this theory called script theory, which is an organizational theory of the mind on how doctors make decisions. So the idea is, how do doctors learn knowledge? How do we structure knowledge? We learn it at Tulane, we learned it in medical school, we learned it in residency. Most importantly, we learn from taking care of patients. That information is compressed and stored in the brain, not like it is in a computer or a library, but it's encoded in these things that we call scripts. So it's encoded in illness scripts that might have the patient's presentation, what the acuity of their symptoms, what symptom complexes might happen, how the pathophysiology plays into that. And then these things don't exist by themselves. They exist in a network, right? So there are a network of illness scripts called schema. What happens when we see a patient? So a patient comes up to us, maybe we see them in clinic, they say, I can't breathe. It started yesterday, it's acute. And automatically our system one kicks in and we build in our mind what they call in research a problem representation. And this might be acute dyspnea. Well, that activates a certain illness script in our brain almost automatically. And that script then feeds back to the further questions that we would ask the patient. So my illness script for acute dyspnea, I might hypothesis test, are they wheezing? Do they have COPD, asthma? Are there risk factors for pneumonia? I'll ask those questions. And as they give me more answers, I refine my problem representation and eventually identify the script where that happens. This problem representation has it's prone to lots of problems, right? It's based on system one. There are a lot of cognitive biases as well as social biases that can affect the way that we encode patients. Even just our practice environment, right? If I work in an emergency room, if I work in the PACU or I work in my clinic, my approach and the base rates of somebody with shortness of breath are going to be dramatically different, and they're going to affect how we think about those patients. So this sounds very theoretical, or I'm an educator, so very educational, but why do we care? Why do patients care? And everyone knows the answer to this. Medical errors and diagnostic errors in particular are a huge problem, not in this country, but the worldwide over. This study was published last year in BMJ, Quality and Safety. Almost 800,000 Americans are permanently disabled or die because of misdiagnosis of diseases. And these aren't rare diseases. The most common one was heart disease. So 15 diseases count for half of all serious harms. Now, not every diagnostic error is due to human cognition, but a lot of them are. So this is a paper that just came out a few months ago in January in JAMA IM from Andy Auerbach's work. Really great methodology. I mean, I can find no fault. Well, there's faults with every paper, but they did as good a job as they could. So they randomly sampled at 29 different hospitals, academic and non-academic institutions, patients who were transferred to the ICU unexpectedly. And they did a detailed chart audit. I won't go into the details of it. They did it very interesting though. But in these patients, almost a quarter of them had a diagnostic error. And these errors were dangerous. Almost 1 in 5 caused severe harm or even death of the patients. And when they looked at the causes of these errors, defects in human cognition by far were the largest contributor. So this is the objective evidence that, some of the problem is because of how the human brain works. So for the last 30 years in clinical reasoning, we've been working, maybe last 20 years, working ways to improve reasoning, really to decrease errors, right? That's been the big focus of our field. There have been 3 categories of interventions. You guys have probably been exposed to all of them. The first is education about cognitive biases, teaching people about, for example, anchoring bias or recency bias on the thought that that might decrease or improve our diagnostic performance. One of the most effective are de-biasing strategies. There's some research on reflection, right? So deliberate practice, getting doctors to reflect on how they've done on cases, that might improve diagnostic performance. Been very difficult to scale. And then the third, and actually the oldest, is artificial intelligence, right? Can there be clinical decision support systems that help reduce errors? As all you know, the effect sizes, especially of the interventions in 1 and 2, have been modest and really only in experimental settings. So that brings us to AI. The discussion we're having about AI is not new. This is the oldest quote that I found that really discusses artificial intelligence, and it's from Bernard Shaw over a century ago. So he's reflecting on when shopkeepers used to have to add things up manually, and now they have counting machines. Mechanical counting machines. And he says, in the clinics and hospitals of the near future, we may quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators, as they now leave the taking of a temperature to a nurse, and with much more confidence in the accuracy of the report than they could place in the guesses of the Royal College of Physicians. The observation of the symptoms is extremely fallible, depending not only on the personal condition of the doctor, who has possibly been dragged to the case by his night bell after an exhausting day. I worked all the day, so I get that. But upon the replies of the patient to questions which are not always properly understood, and for lack of the necessary verbal skill could not be properly answered if they were understood. From such sources of error, machinery is free. This is 1918, and the discussion that Bernard Shaw is having is remarkably similar to why we're talking about AI today. Historically, AI has been quite effective. I mean, if you go back to the 60s and 70s, people were very optimistic. AAP help, for example, this is in the 70s, reduced negative laparotomies and acute abdomens by almost 90%. So remarkably effective. Studies on modern diagnostic AI, also known as differential generators, have been experimentally promising, but they haven't done a lot. There hasn't been much real world impact, again, because of difficulty of scaling. LLMs in my field are the most exciting intervention in clinical reasoning. So what are they? I've said language models a couple times. So a language model is a type of machine learning algorithm that is trained on massive amounts of human text. We don't know everything that goes into it. We do know a lot of it is scraped from the internet, also pirated books. This is the script to Star Trek II, The Wrath of Khan. That's in there too. What happens is that this machine learning algorithm, and it uses a transformer architecture so it can pay attention, but it splits these texts into parts of words called tokens and then calculates the association behind the words. If you've ever used Google autocorrect, it's or like when you type in Google and it fills out, fundamentally the same principle, but it does this on an absolutely massive scale. So you get this like crazy autocorrect that will spit out, whatever you want. You can imagine there's a lot of wonderful things on the internet. There's a lot of terrible things. So it's going to spit out some pretty nasty things. And if anyone ever used early LLMs, they could be incredibly inappropriate very quickly. So this is what makes large language models or transformer models special, is they are fine-tuned by humans, reinforcement learning with human feedback. It's literally a Skinner box. You give a cookie or you give a shock. So, it gives a response and you say, this is a good response or a bad response. And based on that, the model learns. And from that, you get something that is remarkably like a simulacra of human speech. This is the real prompt for GPT-4, asking it to rewrite the Star Trek II script in this iambic pentameter. And as you can see, Khan, he yells, "Farewell, noble admiral, hold not your breath. The Enterprise cannot save, she's marked for death. From the skies, soon shall she be torn asunder, a fiery end, a final echoing thunder." It's really good, right? And I did just want to do the Khan meme in here, but foundation models like GPT-4 they can do other things. They can make images. I don't know if anyone's seen the videos that OpenAI's new model can do. This was from a single prompt, made Captain Kirk in the Globe Theater yelling Khan, right? So you can recreate people's speech, you can recreate videos, anything can go into these transformer models. As a bucket, they're often called generative AI. Okay, so why does this matter for reasoning? This is a real patient I had who presented with this constellation of findings. This patient unfortunately actually died. I have permission from his family to discuss this case. The patient, by the way, was a huge Star Trek fan, so would have loved the fact that we were using an AI. So, about a year ago, my patient had already died. We knew the final diagnosis. This poor man had been treated with BCG for his bladder cancer a year and a half before, and had become disseminated unexpectedly, very rarely, and he died. I asked GPT-4, giving all the information from my problem representation, and GPT-4 got the answer right. It got an answer that none of the doctors had, and its second answer, culture negative endocarditis, was our actual working diagnosis. So when I saw this, as someone who studies clinical reasoning, it was shocking. What's going on? And it has this question, do LLMs make diagnoses because of these token association? Is it similar to how humans make diagnostic decisions? Are these similar to illness scripts? So I've talked a lot. I want to actually demonstrate how this works right now before I go into the evidence. So Alex Stoller, are you there, Alex?
Yes, I am.
Okay, so I am going, well, first I'll explain what we're going to do. And Dr. Chakraborty, are you here?
I'm here.
So Dr. Stoller, MS4 at Tulane, is going to present a real case in 4 sections to Dr. Chakraborty and to Dr. GPT-4. And Dr. Chakraborty is going to tell us his thinking. And then we're going to pause after each section and ask GPT-4 its thinking. You guys ready?
Let's do it.
So this is the prompt I'm using. Doesn't matter, just in case anyone's curious. Dr. Stoller, take it away.
Excellent. All right. Good evening, everyone. As mentioned, I'm one of the 4th year medical students, and this is an actual case I had in an elective just a few weeks ago. It's broken up into a few sections. So this is just the initial sort of HPI that the patient was able to give while in the emergency department. So a 49-year-old male with a past medical history of dyslipidemia and renal cancer, a status post partial nephrectomy, comes to the emergency department after a syncopal episode. Patient is visiting New Orleans from Naperville, Illinois, and states that he felt dyspneic with minimal exertion for a day and has a pressure-type sensation in the mid-portion of his chest. He felt short of breath and lightheaded while walking his dog and had a syncopal episode witnessed by his significant other who activated EMS. Patient was given aspirin and nitroglycerin en route. Since arrival to the emergency department, the patient's chest discomfort has improved. Patient is a never smoker, denies any substance use, and is just a social drinker, just a glass of wine per night. He does not take any medications. Review of systems is completely negative except for what's previously mentioned in the HPI here. So I was going to say, I think it's the point where Dr. Chakraborty, what are your initial thoughts on differentials?
Yeah. 49-year-old gentleman basically has a syncopal episode. Some of the common causes of syncope are hypovolemia, but you have to add with that the shortness of breath, the lightheadedness, and the chest discomfort. I'd have to include something related to a cardiac cause, which sounds like what EMS was gunning for by giving the nitro and the aspirin. Patients discover discomfort improved. Isn't clear if that was in what the timing is with all these things. Whether this is the chest discomfort happened shortly after the patient made the trip down from Illinois. Or whether or not this is the patient has been here for a couple of days. So I think one of my first big questions is I don't have a whole lot of information in terms of timing between all of these things. And second, I'd like to get a little more information, particularly in terms of family history, albeit 49, maybe on a tad on the early side for coronary artery disease.
Well, unfortunately, there'll be no additional history since we're not doing that for GPT, and it's going to be a fair comparison. So with the information we have.
Fair enough. With the information that we have, I'd like to, I'd like to get some vitals, so maybe some orthostatics, and get a EKG and some cardiac enzymes.
So on your differential right now?
I would have to put acute coronary syndrome, maybe a venous thromboembolic cause, depending on the relationship, the temporal relationship with the travel down to New Orleans. And then more prosaic causes of syncope like hypovolemia. Maybe they're not used to our heat and humidity down here.
Now we will ask your artificial intelligence colleague what it thinks. So honestly, a remarkably similar problem representation, right? Picking up on the dyspnea on exertion and pressure discomfort, and also picking on the fact that the patient was given aspirin and nitro. Their differential, ACS, similar to you. Number 2, thromboembolism. Picking up number 3, arrhythmia. It's continuing to go. It's putting aortic dissection in there as well. And it wants, very similar tests. It wants an EKG, troponin levels, a dimer, a echocardiography, and a CTA, depending on what the dimer shows. Okay. Dr. Stoller.
Okay, excellent. So next thing in the emergency department, they got a set of vitals, like Dr. Chakraborty mentioned, slightly tachycardic at 106 and slightly hypertensive at 153/86. But overall, the rest of the physical exam, there wasn't really anything of note that the patient had, and most of his symptoms had actually resolved by the time of the physical exam. So as you can see, saturating well, is afebrile, and actually respiratory rate is within normal limits as well.
So, if I can comment, the physical exam looks largely benign, a little hypertensive. SpO2 is pretty good. Heart rate saw slightly on the tachycardic side. Certainly right now, nothing is arguing against either acute coronary syndrome or pulmonary embolism. A quick and dirty thing that we could do for aortic dissection, oftentimes in the emergency room, is getting blood pressures in both arms. Obviously, we don't have that here. But the characteristic of the description in the previous slide didn't really sell me on aortic dissection, like the tearing chest pain that we typically hear. The description of the discomfort, shortness of breath, and chest pain seems a little bit more, in my mind, aligned with acute coronary syndrome than aortic dissection. So I'll stop there. I'm still looking at PE versus ACS.
All right, we will see how your mechanical colleague, whether or not it agrees or disagrees. It's hard not to anthropomorphize them. So again, it also picks up on the fact that maybe there's mild tachycardia, but that otherwise this is a largely benign physical exam. Yeah, and the differential is unchanged. ACS, pulmonary embolism, arrhythmia, pointing out that perhaps the tachycardia could be a misread of an arrhythmia. Aortic dissection. But here, updated does not fit. Lack of described tearing differential doesn't fit. So far, the AI does appear to be, it appears to be trained on you, Dr. Chakraborty. Okay, Dr. Stoller.
All right, excellent. So as Dr. Chakraborty mentioned, a couple of other tests were ordered. They got an ECG, just noted significant ST depression and some T-wave inversions in the anterior leads, but no STEMIs or ST elevations. For the most part, most of the lab work came back within normal limits, so chemistry, CBC, and things like that. The only thing really in note, at least in the emergency department, was an elevated troponin and an elevated BNP. But for the rest, while this is going on, this is a few hours after the event, and patient is actually feeling almost like they did pre-syncopal episode.
Yeah, I think, you know, certainly some of these things can still occur with either an acute coronary syndrome or, you know, a little less commonly, but still can happen with a pulmonary embolism. I think that nothing is really dissuading me from either of those two diagnoses. I think based on what we're seeing with some of these preliminary results, it looks like it's a little bit more in line with acute coronary syndrome. You know, I'm not actually seeing the 12 lead EKG itself, but I'm not seeing evidence of acute right heart strain. I'm not seeing evidence of the S1Q3 T3 pattern that would suggest a pulmonary embolism as the underlying cause for the EKG abnormalities. Troponin being elevated and the BNP elevated largely means that there's something going on with the heart, causing some heart damage, causing some ventricular stretch. But the root cause of that, whether that's coronary artery disease and it's a acute coronary syndrome, or whether that's from a blood clot in the pulmonary vessels, that remains to be seen.
Okay, we will see how, again, Dr. GPT thinks about this, and if this changes Dr. GPT's thoughts. So, just as you, Dr. Z, GPT thinks that ACS is the most likely cause. Yeah, and with a high probability. PE is still number 2 on its differential. I think it's finding that these EKG changes, as you mentioned, are not the EKG changes that you would expect with a PE. It's keeping arrhythmia in the differential, though pointing out that there's no arrhythmia on the EKG dissection. It's still on here, but yeah, it feels that ACS in particular and NSTEMI is the most likely diagnosis, with PE and aortic dissection still there, but less likely. Okay, Dr.
Sure, yeah, excellent. I know, so I mentioned here, there was a chest X-ray done, which was completely unremarkable. So the physician in the ED actually ordered a CTA and showed a bilateral pulmonary aortic thromboembolic disease with signs of right heart strain. Found to have left main venous thrombus in the left main pulmonary venous, and right upper lobe venous thrombus as well. And I should mention, this was actually a radiology case for me, and it was the first time I'd ever seen a bilateral instance of this occurring. So it was very, very evident as soon as they came in via the CT to the radiology suite.
Yeah, like I said, some of the heart's findings could have been the root cause, whether there was coronary artery disease being the root cause, or certainly a pulmonary embolism being the root cause of the heart damage. All those labs were saying was that there was myocardial damage from the troponin bump, and there was ventricular stretch from the BNP. So, yeah.
And as I imagine that, yeah, GPT-4 similarly updates its what do they say? There's considerable significantly updated. Again, pretty obvious at this point, putting PE at the top.
Excellent. And so everyone, just to give everyone an update on what happened with the patient, is doing very well today. A patient while in the emergency department was given some Lovenox, a little bit of that morphine initially due to some of that chest pain, as well as heparin and aspirin, and a bolus of saline of 1 liter. And essentially from that point was admitted to internal medicine for further workup. Was there for about a day. And so what they ended up doing, they actually consulted IR just due to the size of the PE, of the bilateral PEs. And sort of they eventually ended up doing a thrombectomy in both sides, and sort of bilaterally. Additionally, the patient did have an ultrasound of sort of both lower extremities, completely unremarkable. Also had a TTE, which just mentioned the moderately dilated right atrium and right ventricle, and just a mildly reduced ejection fraction. So after he was with IR, I believe about 2 days later, he was discharged on Eliquis and atorvastatin and was sent for his PCP for follow-up. And in case anyone is wondering, with regard to the travel history, it was actually a 6-week difference between when the patient drove from New Orleans, from Naperville, Illinois to here. And so I think everyone was initially assuming that being there for that long might have been the case. But I know that's quite a bit of time between travel and maybe an episode. But I think that's what a few people might have anchored on during the diagnosis.
So Dr. C, I mean, this wasn't a particularly difficult case. I think any human would have done just fine here. I'm curious about comparing your reasoning to the AI's reasoning in particular. Did anything strike, was anything surprising to you? Did anything stand out?
I mean, it was surprising, I think, how closely it resembled my own reasoning. I've played around with ChatGPT myself, not in a diagnostic sense. So this was illustrative to see how it thinks, so to speak, and how closely it replicates. I will say that one thing that I noticed, which was a little interesting, is that one of the earlier recommendations from ChatGPT was to potentially get a D-dimer. And, you know, we in the internal medicine world, we like to nerd out about the utility of D-dimer according to pretest probability. And I would be in the camp to say that this patient probably shouldn't get a D-dimer and should go straight for
Right.
a CT-PE protocol.
Right, high enough pretest probability, there's no point. A dimer isn't going to change your management one way or another.
Exactly. So I think that was the only thing that stood out as a difference between the way I was putting this together versus the way AI was putting this together. But otherwise, I think I'm surprised about how well it performed, or how similarly it performed.
And interesting, of course, to talk about metacognition. The metacognitive task you were doing there is different than the rest of what you're doing. It was, what you're saying is explicit Bayesian reasoning, right? It didn't do any explicit Bayesian reasoning. The rest was other metacognitive strategies.
Exactly. Yeah. And quite honestly, that's, you know, some aspect of the discussion of PEs that have evolved ever since the D-dimer test really hit the airwaves, so to speak.
Yeah.
So, you know, that was something that we didn't really have in our back pocket when D-dimers were first introduced. We had to get to that point through a lot of trial and error.
Well, Dr. Chakraborty, thank you very much. I should show you, you would love to see how this performs on a trickier case, because the same reasoning you're seeing now, it can do it on pretty much any type of case. It's quite interesting.
Amazing.
Okay, I'm going to thank you, Dr. Stoller, for presenting the case.
Yeah, thank you much.
I'm going, now that we've demonstrated this, again, it wasn't a particularly difficult case, but I want to go over what the evidence shows, because there actually is a pretty strong evidence basis that what we've seen here is not a fluke. So one of the first things when LLMs came out, they are language models. There was a lot of interest in showing to what degree they encode knowledge and medical knowledge. And how do we do that? Multiple choice tests. This on the left is a graph for MedQA, which is a question bank that's used in benchmarking. You can just see how these models have improved over time. GPT-4, what we just saw, out of the box GPT-4 gets like a 265 on step 1, and step 2 CS and step 3. Similar, like you can see these are the percentages, but it gets like the score that would get into any single residency that anyone would want in the country. It doesn't necessarily do as well on the subspecialty exams, but encodes a ton of medical knowledge. This is a study that also got a lot of press. This was just GPT-3.5. Limited, but still interesting study. So it looked at a web forum. So responses from actual patients. And then they did a Turing test. They looked at the doctor's responses and the AI responses. And most people who were blinded preferred the GPT-3.5 response. It had higher ratings of both quality and empathy. Here are the graphs, the empathy ratings. You can see like there's very little overlap, right? The AI was far more empathetic, and this is GPT-3.5. And, you know, one of the concerns, one of the criticisms was, okay, well, GPT writes, LLMs write a ton, but even when you control for length, people still preferred the response of the AI. A limited study. So diagnoses, as we've shown, there have now been a bunch of studies showing that AI can make diagnoses. GPT-4 in particular could get the top diagnosis in the differential 64% of the time when solving the Newly Journal CPCs, which everyone knows are incredibly difficult. That number, the models have improved. Now they're getting it about 85% of the time with the new versions of GPT-4, and Gemini Ultra 1.0 performs remarkably similar. I think the numbers were pretty much exactly the same at solving these cases as a benchmark. Google did a really fascinating and I think dispiriting study. They were like, their question was, when solving these cases, how does the AI change human performance? This is your classic human-computer interaction study. So they had 4 groups solve CPCs. They had humans alone. They had humans using Google search, right? So the idea that, oh, is it just a search engine? Then they had humans using this fine-tuned AI they had done. This was not GPT-4. This was a fine-tuned version of PaLM 2. And then finally, they had AI alone. And unfortunately, what you can see is the AI alone performed by far the best, right? Humans are the worst. Humans plus search do a little bit better. Humans plus AI do better. AI alone does the best, which means that AI, like humans got recommendations from the AI and just said, I'm not going to listen to that, and it decreased their performance. Can LLM show reasoning? The reason that I showed you this presentation that Dr. Chakraborty and Dr. Stoller volunteered their time is not to show that it can get the answer, but to show the mid steps, right? The reasoning process. Stanford tested this really interestingly with their clinical reasoning exam. Open notes, you can write whatever you want. They use a take-home test, but they gave it to GPT as well as medical students. And they scored it. It was blinded. And GPT-4 outscored the medical students on a clinical reasoning exam. Google did a similar thing when they evaluated PaLM 2, looking at the presence of reasoning. This is a pretty early study. The methodologies are very basic. But what's interesting is you can see, yes, humans show good reasoning most of the time, but they don't always. So humans show mistakes in reasoning. The medical AI shows a little more mistakes in reasoning. The general purpose AI shows many more mistakes in reasoning. One of the interesting things that I'd say my earlier research focused on is how is the LLM making these diagnoses and what is the relation? And one of the interesting things, this is an experiment, we had 553 humans solve cases, probabilistic cases, what like Dr. C was doing, where you would have to say, what is the pretest probability of this disease given a presentation? How does that change after a test, either with a negative test or a positive test? In this, you can see the blue box is the actual answer. The green box is the humans, and the red box is the AI. And what we found surprised us, which is that the AI smokes the humans, right? It has less absolute error in all of the cases of estimating pretest probability, in all of the cases of post-test after a negative, and in most of the cases of post-test after a positive. Otherwise, it's equivalent. This doesn't make sense. They have no experience of the world. They don't know epidemiology, but they seem to have this emergent probabilistic understanding of the relations between diseases in a way that outperforms humans. So this is a study that's coming out in JAMA IM in 2 weeks. This is a human trial that I did looking to actually quantify the reasoning and looking at other process intervals of the reasoning process taken from the clinical reasoning literature. In figure A here, you can see how GPT-4 performs versus attendings versus residents in a measure of the content of reasoning called the RIDEA scale. You don't need to worry about the details, but the gist of it is, again, the AI dramatically outperforms humans in the content of reasoning. Attendings are a little bit better than residents, but AI is much, much, much better. There was no difference in efficiency, accuracy, quality, or cannot miss diagnoses. What's interesting, what our study found is there's a trade-off. There's more examples of incorrect reasoning with the AI. None of these were major examples, but it would make tiny mistakes. But humans did too, but AI did more. So this interesting trade-off. This is a randomized control trial that the preprint is coming out today. It hopefully will be published in a couple months, where we randomized people to solve very difficult cases, same as Google did, either with the AI or with standard care, or with, GPT-4 alone. And we looked at a number of different outcomes. And one of the most interesting things, as you can see here, humans, adding the AI did not make the humans any better. There was a signal for humans who were very used to using, who were most familiar with GPT. There's a signal that they might do better, but the AI alone dramatically outperformed humans alone and humans plus GPT. There were some other differences that were important. There was much more efficiency. So people who use GPT could solve cases much better without losing accuracy. And there was a signal towards having the final diagnosis. But this is another, now that there have been 2 prospective trials that show that AI alone is better than humans plus AI, this seems to not be a fluke. LLMs are also able to forecast, make probabilistic decisions about diagnoses better than humans. This is another study that we've done. It's being reviewed right now. It hasn't been published yet. But AI can make forecasting decisions better than individual humans and better than groups of humans. We did compare AI to, if you take all the best guesses of humans together, that still outperforms AI. What we did not study is what happens when you take AI and human guesses and put it together. But another example that AI is actually able to perform some of these predictive tests better than people. This is a study that I helped design. This is got a lot of press. So this is a Google study of using a really interesting LLM that they trained on self-play called the Articulate Medical Intelligence Explorer. They got a bunch of standardized patients, a bunch of cases, and then they had the standardized patients have their history taken through a computer. That computer was either a human being on the other end or the AI. The patients did not know. The AI took the history, and then it was graded using the UK PACES exams criteria and the NBME criteria for Step 2CS. And effectively, AI beat humans in 28 of 32 axes and was the same in the other 4. It made better diagnoses. It had a higher diagnostic accuracy. The best that humans could ever do was tie it, but it beat humans in almost every domain. And these were consistent throughout, different types of diagnoses. And there were a lot of different cases here. Now, everyone should know, I think this gets a lot of press, but it is true and it's important. LLMs are trained on human-generated material, and because of that, they contain the biases of their pre-training and their fine-tuning. So this is from a great study in BMJ, where GPT was asked, the API was asked to create clinical vignettes, and effectively what it does is it gives a stereotyped and not an epidemiological understanding of disease. So you ask it to create 100 cases of sarcoid, 98 times it's going to create a Black patient. Well, in reality, Black patients are only about half the cases of sarcoid. And it does this, we looked at many different domains, but it does this across the board, right? It does have this sort of stereotyped understanding of disease epidemiology. Similarly, there's a famous experiment where humans are shown to recommend advanced cardiac imaging less frequently for Black women than white men. GPT-4 also has those biases, though less than humans. But these things are baked into the way that these models work. So for just a few minutes, no one ever wants to hear someone talk about their own research, but to talk about the things that me and my lab are working on. So one is what I've said this word a couple times, HCI, human-computer interaction. So how do LLMs actually change human behavior? The reason it's interesting is this meme. I don't know if anybody's seen this before, so I'll explain it. This is a tentacled monster called a Shoggoth. This is from H.P. Lovecraft, Massachusetts horror writer from the 1930s. He wrote all the Cthulhu stories, and the Shoggoth is this horrific tentacled monster. And in these stories, the monsters aren't evil. They're just so powerful that they look onto humans the way that we look onto ants, right? They don't care if we live or die. On the left, it says Shoggoth and it says GPT-3. On the right, it has the Shoggoth holding up a little smiley face mask, and it says, I simply exhibit the behaviors that were engineered into my programming by my creators. And it says above, GPT-3 plus RLHF, reinforcement learning by human feedback. What does this mean and why is it important? These are LLMs, including the LLMs that we just used and saw now, are these bizarre monsters that are not human. They're trained on our text, but they have bizarre associations. And we fine-tune them by telling them what's good and what's bad, but they're still making these bizarre associations behind the scene. About 10 months ago, the New York Times had the story from Kevin Roos about how Bing's search tried to break up his marriage and marry her, Sydney. The way that Microsoft stopped this was not to like reprogram the LLM. It was just to shut it down whenever it started talking about crazy things. The fundamental point being large language models are uninterpretable. We can never know, mildly controversial statement, but we can likely never know why they make the decisions that they do. So when you do that, there's these really important questions. Like if you're never going to know why it's saying what it does, how do you make sure that these systems are doing what we want? How do we, it's called alignment. How do we align them with human thought processes and values? This is important from a regulatory perspective, right? The FDA does not currently have a way to regulate these. Software as a medical device is a current regulatory domain, and it is not capable of regulating this. But then from a scalable oversight, like, sure, we're going to have a lot of human in the loop systems in the beginning, but I will tell you right now, these technologies are incredibly powerful. There is going to be a lot of pressure to implement them, both for cost savings and for safety savings. And how do we humans keep track of what these machines are doing? How do we make sure they're doing what we want? How do we make sure they're not doing something crazy? So that's one of my research. And then the third, and this is what I'm doing, how do we do human subjects research, right? How do we do randomized control trials in people? I am launching one here at the BI. We're going to publicly announce it pretty soon. And we're taking like incredible steps to ensure safety of participants. But this is a type of research that we've really never done before. So, figuring it out, that is pretty interesting. So I think I managed to do everything I said and leave 10 minutes for discussion. So with that, I'm going to stop talking and turn this over to everybody else.
All right, so I'm monitoring the chat, so please send your questions. So first is just someone wants you to share the reference for empathy scores study. So just after this. So we'll go to the first question, which is what are ways AI can increase clinic flow and efficiency?
So great question. Kaiser in New England Journal Catalyst published their experience with the integration of an ambient listening. I don't know if anybody's used an ambient listening program. It's not, the big ones are DAX. So that's the Dragon and Nuance's Dragon software. And then Abridge, they both use GPT-4. But Kaiser in Northern California went with another one, and they implemented an AI scribe. And the amount of time that the Kaiser doctors spent on charting went down almost 80%. Guys, that's an 80% decrease on charting time because it just listened in the clinic visits and then fit the entire note. It wrote it for them and formatted for them. And then a couple hours later, the doctor just had to read it and approve it. So in terms of what's coming right now, I mean, DAX and Abridge are out there. A lot of clinics have implemented them. So ambient listening is the first thing that is going to change our workflows for the short term. Other documentation tasks are going to be taken. So there's a really interesting study actually published just 2 days ago in JAMA Open from NYU. NYU is doing a lot of work in this, showing that you can create discharge summaries pretty effectively from information in the chart. There are trade-offs between how long it is and completeness, but I expect that within a year, probably humans are no longer going to write discharge summaries. Other flow things that you might think, how are we going to interact with our charts? For example, I want to know how my patient's heart failure medications have changed over time. Right now, I pull up a bunch of flow sheets, I read a bunch of notes. In the not too distant future, you're going to ask a chatbot, tell me about this patient's heart failure medications, and it will graph out just for you from scouring the chart what is going on. Now, longer run, there are going to be many more changes to our clinical workflows. But I think that anything that requires scalable oversight, that is a human not in the loop, that is a much harder regulatory piece and safety piece. And we're not going to be seeing those probably for, who knows, but let's say a decade. All right.
So along those lines, next question is, how are AI models built for medicine while avoiding HIPAA breaches? And then second part, have the patient notes and physician opinions used in training been gathered with their informed consent?
Wonderful question. So I'll take the first one. So this GPT-4 is a general purpose model. Your question is really interesting because it's a huge debate in the field. Are general purpose models going to be more powerful? So is GPT-5, is Gemini Ultra 1.5 going to be the way that medicine goes? Or are they going to be medicine trained models? So for example, Florida State trained Gatortron or sorry, Gator GPT, which is trained on their clinical notes. Right now at MGH down the road from me, they're training a model on their clinical notes. If you train something on the clinical notes, will it improve? We don't know the answer to that. A Hippocratic AI is a startup out there. This is their entire MO. They're training it on and using clinicians for fine tuning. Now, your question is great. The ethical issues of using patient notes. So GPT-4 does not have any patient notes in it. Its knowledge does not come from patient information. What about Gatortron or Gator GPT or NYU? They, like, the person who owns the notes is the hospital system, right? And the hospital system does not need to get consent to use the notes. If you want to be really scared, think about it this way. At some point, a startup is going to find an unethical hospital system to somehow sell it its clinical data and then use that data to train a commercial large language model. This is really concerning because if you have a large language model, things from the training data can come out. PHI is presumably, like for Gator GPT, they just use it for research, whatever. It's not a big deal, but it can leak like protected health information. So these are huge concerns, and there is not a regulatory environment right now.
Thank you. Okay, another question, and we're coming down to the wire. We have 6 minutes. Can you please speak to your advice for future clinicians and researchers to position ourselves to both utilize AI, but also be part of the development of this technology in the clinical setting?
Yeah, that is a wonderful question. So this is tough because it's hard for me to give specific advice based on your experiences. It is essential that practicing clinicians partner with AI researchers, right? I gave a talk at the at Harvard Biomedical Informatics yesterday. So it's all PhDs, and they are thirsting to work with us because a lot of the questions that they need answered, right? They're building the technology, but they have questions like, what does it mean to make a good decision? What is a good outcome? How do we think about like safety for prescribing these medications? And these are things that only physicians can answer. Well, I shouldn't say that, it's a little arrogant, but physicians are like, it's something that we need to work together on. So now is the time for anyone who's interested in this to like find research groups in your area. Like I'm sure you have a biomedical informatics group. You probably have computer science. Start collaborating together because our perspectives, I think, are essential to making sure that this technology serves both us and our patients and doesn't just like push us to the sidelines.
Great answer and great question. So, okay, now, Adam, any thoughts on how this might be used when teaching clinical reasoning to medical students and residents?
Great question. I use it all the time in teaching clinical reasoning. One of the best things that LLMs can do is they display good clinical reasoning. You can teach them to display even better clinical reasoning, and they will always show their work. So we actually have a case series here at the BI that we do with the AI, right? And we're not like saying whatever the AI does is right. We're using it as a framework to have further discussions and to use our metacognition to think about our thinking.
Okay, I think we have time for a couple more. Is there any settled or established law regarding liability from AI-derived treatments which may cause harm? Who is responsible? This may open up a Pandora's box question.
So the answer is quite easy. The doctor is responsible. There is no legal framework. So the legal framework is called software as a medical device. Software as a medical device is meant for things such as the EPIC sepsis score. And there are criteria for those of you who work in radiology, you probably use AI algorithms that have gone through software as a medical device. Like I've mentioned, LLMs cannot be regulated by that. So there is not a regulatory framework right now. If something bad happens, it's on the doctor who used the AI. It is not on the AI company. That will likely change in the future. Just based on what I've told you, you can see how hard it is to regulate and come up with a regime to make sure these things are safe. Now, the interesting thing that I'll say is that, and this is either good or concerning depending on your outlook, things like AI scribes and things like summary are likely going to be found exempt and not have to go through FDA regulation because of the way software as a medical device is written. So that's why it's really important that we make sure those things are safe, because I don't think the FDA is going to regulate them.
Thank you. So as a reminder, if your questions were in the chat and they were not answered, we will get to those after the WebEx. So With that, I'm gonna thank all our speakers for a very informative and fun presentation. I hope that everyone is as excited as I am about the future of medicine and how we can implement AI to improve patient care. If you place questions on the chat, as I said before, we will get to those after this. The webinar has also been recorded and all registrants will receive a link to the recording. And I want to again thank the audience for attending, thank our speakers once again. We encourage you to fill out a short survey that's coming to you after this so we can continue to improve our content, and have a great evening. Thank you.